Чи ви нас чуєте, професор Jörg Fegert? Кивніть, якщо ви нас чуєте.
Yes, I can hear you.
Професор Роберт,
I can hear you, Dr. Bulavinova.
ви нас чуєте?
Can you hear me?
Yes, we can hear you.
Добре. Тоді, якщо всі спікери нас чують, добрий вечір усім. Ми раді вас вітати на нашій серії, яку ми робимо разом з ESCAP. І я всім нагадую, до того, як професор Jörg Fegert буде представляти спікерів, я всім нагадую організаційні питання. Ви можете дивитись зараз, ті, хто дивляться в Zoom, там є кнопочка, де ви переключаєте мову, з нами працюють перекладачі, тобто ті з вас, хто хочуть дивитись англійською, будуть дивитися одразу англійською, ті, хто дивляться українською, будуть дивитись українською. В записі на YouTube ви будете мати і українську, і англійську версію. Якщо наразі щось стається з Zoom, ви можете одразу перейти на YouTube, і там буде цей запис. Підписуйтесь, будь ласка, на канал доктора Булавінова і на мій телеграм, щоб отримувати інформацію про наступні ефіри. Все це буде у вас в коментарях до цього зуму. І нагадую, що ви задаєте питання, і ми в кінці будемо задавати питання всім спікерам. Тобто обдумайте свої питання, пишіть їх в чатик, і ми будемо їх задавати. Сьогодні нема з нами пані Оксани Збітнєвої, вона десь щось, якась в неї важлива зустріч, але вона, як зазвичай, передає вам всім вітання, бо ми все це робимо разом з Координаційним центром Кабінету міністрів України, разом з Міністерством охорони здоров'я, разом з Національною службою здоров'я України. Я Катерина Булавінова, медична експертка ЮНІСЕФ в Україні. І наразі я передаю слово професору Йоргу Фегерту для того, щоб він відкрив нашу сьогоднішню серію. Прошу, Йорг.
Yeah, thank you very much, Dr. Bulavinova. It's a pleasure to introduce today a very special webinar. We, as ESCAP, as the European Society of Child and Adolescent Psychiatry, work together with WHO Europe for some years now, and we had common symposia at our Congress. And in Athens, there is a special group led by Dr. Jennifer Hall, who is present here this evening, that works on quality standards for child and youth mental health services. And our co-chair of our policy division, Robert Vermeiren, worked together with her, came to Athens to present and met the WHO Youth Panel. And I'm very glad that 6 members of the WHO Youth Panel are also part of this webinar this evening and will intervene. It's Hannah Brunskill, Paul Fiedler, Kateryna Sidiroglu, Marina Royo Marco, Spiros Kronis, and Sophie May Harrington. And then we have an expert by expertise. It's Paley van Tilburg. She also presented at our ESCAP Congress, so we met personally, and I'm glad to see you again. And the senior researcher that we also met at these meetings is Caroline de Beer. She presented also at the 2025 ESCAP Congress. The first speaker this evening will be Dr. Jennifer Hall. I already mentioned her. She's an expert in international public mental health. She currently leads the WHO Regional Office for Europe's work on improving the quality of child and adolescent mental health care, and works with stakeholders across the region, and region means whole Europe, to really get real-world impact. She has over 17 years of international experience. First, she worked in UK. She also worked in Uganda. And I'm really very glad about that cooperation. And I don't want to steal your time because I find it fascinating that you brought together a really big panel to give us some insights in your work. And as I mentioned to you, I really admire the Ukrainian colleagues that every 2 weeks attend these webinars very attentively, and be prepared. You will have a lot of questions at the end. We always have a lot of discussions, and time is not enough to answer all questions, but I find it really fantastic in these difficult situations that all these colleagues in Ukraine are coming in the evening, attending these webinars, just to learn more about different perspectives of child and adolescent psychiatry in Europe. So, Jennifer, the floor is yours. Perhaps you can share your slides and start with your presentation.
Absolutely. Thank you very much, Professor Fegert, for the lovely introduction. And indeed, it's always an absolute pleasure to collaborate with you. And thank you very much to, of course, yourself and to ESCAP for inviting us to present on this webinar. I am just sharing my screen. And of course, a huge greetings to everybody who is joining this webinar as well. It's great to see so many people here today. It's very inspiring to see how many are joining. So today I will cover a bit of the overview of our WHO office here and quality of care and patient safety. I am joining you today from Greece, from Athens. And then I will cover a little bit about our European programme on quality of child and youth mental health care, as well as our quality standards. So, as I mentioned, we have this office here in Greece, and we are part of the WHO Regional Office for Europe. And we are an office dedicated to quality of care and patient safety. And we have been set up in collaboration with the government of Greece. So you can see here a picture of our regional director, Hans Kluge, as well as the Prime Minister of Greece. So really to say that this area has a commitment from the highest level. One of the core work streams under this Athens office on quality of care and patient safety is this WHO European programme on quality of child and youth mental health care. And this programme, it is very special in that it is a collaboration between our office in Copenhagen and our mental health and well-being team, which is led by our regional advisor, Dr. Ladir Lazari, who I'm sure some of you on this call will know, as well as our head of office here in Greece, Dr. João Breda. And one of the reasons as to why this program is so special is because it is the first globally within WHO set up to strengthen the quality of care for child and youth mental health. So it's really bringing together these two areas of quality of care and child and youth mental health. And I would say we are leading the way in many of the things we have developed because we are the first to focus on this. So it's a real pleasure from my side to be leading this work. And we have a very strong team here in Athens, which is also comprised of our youth advisory group, who I'm super happy are joining us today, and you'll meet some of the members. So to start off with, I have some statistics here about why child and youth mental health is so important and a growing public health concern. Actually, I imagine most people on this call already know how much of an issue it is. So I probably don't need to go into these statistics in so much detail, but they are based off a report that we launched at the end of last year, where we brought together as much data as possible that we have at a WHO European region level on child and youth mental health. I'm sure it will not surprise anyone on this call to say that we actually found that what we don't know about child and adolescent mental health is much more than we do know. We found that lots of data is missing. But the data that we do have shows this increasing need for child and adolescent mental health at a time when actually it's very difficult for countries to be meeting these needs. So we found that there's a lack of specific policies and plans for child and adolescent mental health. There's a lack of workforce. Again, I'm sure you know this is the case since you are working in this area, but really to validate that actually there is this huge lack of workforce across the region, and most children and adolescents who need mental health care will not receive it. Here are some of the challenges that we've heard across the region. So I've been with the WHO office here in Athens since 2022, and this was when the program was set up. So I've been with it from the beginning, and what we did in our first initial phases was to do some consultations to understand what are the issues. We heard things such as there is inconsistent quality of care across providers, services, and areas, even within countries. We heard about long waiting times, that there is no regulation of mental health information in online spaces. I'm wondering whether these are similar challenges to those that you are seeing on the ground in your context and day-to-day life as well. But really, these consultations showed us there is a strong need to strengthen quality of care for child and adolescent mental health. And it is across this background, with these statistics showing the increasing need, as well as our consultations really showing that this is an issue on the ground, that this WHO program was set up. We have 4 main work streams within the program. One is to co-develop our priorities for going forward. So this involves lots of stakeholder consultation, and our youth advisory group are a core part of this as well. But we also have other networks that we call upon, and we co-develop our materials. Within co-developing our priorities, we are also strengthening the data and the research. So this is a really strong part of our work, as we know that research is lacking. A second priority is, as WHO, of course, it's country support. We work with ministries of health to support with anything they would like on strengthening quality of child and youth mental health care. We have quite tailored specific country support, but we also support countries in groups. So for example, we actually, in collaboration with UNICEF, we had a special focus on the Western Balkan countries. We also have youth engagement as one of our core priorities. We've mentioned already our youth advisory group that we have internally, but we also advocate externally for youth engagement in the process of strengthening quality of care, from policies to services, in terms of service design as well as service delivery. And we advocate for this through research publications as well as our communications. And we are co-developing a guide as well for strengthening youth engagement. And our fourth priority is around capacity strengthening and innovation. We provide an annual autumn school, and we also provide regular webinars as well to strengthen capacity in this area. And we know we need innovation to strengthen quality of child and adolescent mental health care. Since this is an area which every country globally is struggling with, we need new ways of doing things. So innovation is really a core part of what we are working with. So this is an overarching view of all of our work streams. The quality standards are one of the main tools we have developed under this. So the need for quality standards, it is around that there was no common definition of high quality care. Actually, the need for quality standards came as a request to us from our Pan-European Mental Health Coalition, which is a group of stakeholders who support with our work. And it came from countries as well. So here are all the issues that we found, and this kind of reiterates the need for why we need to standardize quality of care. We need every child and young person who needs support to be able to access high quality care. So here is a quick definition of what we mean by quality standards. So statements that define high quality care, they should be measurable, and then quality indicators can be based off those statements. And here is our vision with the quality standards, is that all children and adolescents and young people should be able to receive high quality care, regardless of where they access it. So to begin with, we were thinking about our methods to develop the quality standards. It took us a long time, this process actually in the end, because we wanted to make sure that the quality standards themselves were representative of not just research and evidence, but also the voices of those who have experienced the services themselves were included, including caregivers as well as children and young people. So really we prioritized the evidence base alongside this lived experience expertise, as well as professional expertise. And we took a long and comprehensive process, which was balancing these three different expertise levels. And we had a steering group to support us as well. And you can see here, we had literature reviews, reviews of other quality standards, many consultations, and an iterative feedback and update. We actually finalized with a public consultation as well. And we have published on these methods. And here is a young collaborator of ours who was really talking about what high quality care means to her. We can see here it's about it being user focused, users at the center of every decision. So here are the resulting quality standards. The QR code is here, so you can scan it and have a look for yourself. Basically, the aim of these is to provide this framework by which to assess and strengthen the quality of child and youth mental health services. There are 15 standard statements across these 8 themes here. And you can see the themes that came out as important are around this. Again, we talked about user engagement a lot. Participation and empowerment came up. Rights and safety, family and community engagement, these smooth transitions between the services, support that is delivered in a timely way, it is developmentally appropriate and evidence-based, and by a competent and appropriate workforce, and having this quality improvement and data collection at the center of it all. So I really encourage you to take a look at the quality standards, the statements are in there. And what we're doing now is we've also gone through a pilot process because we want this document not to just be a document that sits on the shelf, but we want it to be usable and helpful. So within our pilot process, which we did across 4 different countries, we have been learning what support might be useful. And from WHO, we have developed an audit tool, which will be launched later this year. Actually, here they are. We have an audit tool, which will be launched later next year. As well as we have developed a wider mapping support systems tool, which supports countries to map the multi-sectoral systems that exist within a country from which they can prioritize which service or area they would like to strengthen quality of care. And then we've also brought together evidence and data. However, I would say we are super open. If there are any other tools or resources that you think would be useful for the implementation of the quality standards, please let us know. We are very open to different ideas, and we're also developing a training and capacity building on how to implement the quality standards. And here is my email address. Of course, please feel free to reach out in case of any other questions. And now I will stop sharing my screen. And it is my pleasure to hand over to our WHO Youth Advisory Group, who I have to say are really a fantastic source of collaboration for us, and they really do change our work and make our work more innovative and relevant. I will hand over to Hannah Brunskill, who is our consultant who leads our Youth Advisory Group. So over to you, Hannah.
Thank you, Jen. And hi to everyone. It's lovely to be here. So I'm, like Jen said, I'm the consultant working with WHO in Athens. And my main focus is youth participation and getting to work with the lovely Youth Advisory Group. So today it's my pleasure to introduce 3 of our YAG members who will share a little bit more of their reflections on the first 3 of the quality standards. So first I'd like to invite Paul, who will speak a little bit about rights and safety. Thank you, Paul.
Thanks, Hannah. Hello to everyone, or good evening. Thanks to Jen as well for introducing the quality standards or the quality themes. And yeah, I like to reflect on the second quality theme, rights and safety. I can't imagine how young people in Ukraine must feel, but what I can imagine is how they are going through the process of looking for support, how they might reach out after months of anxiety, after losing loved ones, after feeling helpless or lonely. If they reach out to mental health services, what will they find? Will they encounter care that listens to them, respects their rights, and keeps them safe? Or will they face barriers, stigma, lack of resources, providers who don't understand their needs? This is precisely where the Quality Theme 2 is essential. It ensures that young people, their families, caregivers, but also staff, are treated with dignity, respect, and safety. And with over 2 million Ukrainian children requiring mental health and psychosocial support, facing heightened risks of PTSD, anxiety, and depression, this standard is about leaving no one behind, because every young person deserves care that heals, no matter their background or situation. And when this care is respectful, rights-based, and delivered early, it can empower young people to build resilience, engage with their communities again, recover from trauma, and also reduce long-term suffering, laying the foundation for a healthier future. The war has made mental health care harder to access, but Ukraine is taking action, developing the target model of mental health and psychosocial support, and implementing the National Mental Health Action Plan. Together with the presented quality themes and quality standards, these efforts are building a youth-centered system, ensuring that even in the hardest of times, the care that young people receive protects their rights, keeps them safe, and protects their potential.
Thank you for such a lovely reflection, Paul. And next, we would like to invite Kateryna to share her insights on family and community engagement.
Thank you, Hannah. Good evening, everyone. I will present the third quality theme, family and community engagement, but from a youth perspective. And why does this matter? Because we don't exist in a vacuum. For young people, mental health is not just individual. It's shaped by our families, friends, and wider community. Services should include families and caregivers in our care, but only when we feel it's safe and right. When that happens, we stop feeling alone. Often we think that no one gets it, especially when those around us don't have the tools or understanding to support us. This is why psychoeducation and mental health literacy are important. This approach gives them the knowledge so they can stand beside us instead of guessing. At the same time, it honors our agency. True engagement doesn't take away our voice, it strengthens it. It means asking us, who in your life do you trust? Who makes you feel safe? And then it invite those people in. Also, for me, these standards are important because I am always complaining about stigma in small communities like the one I grew up. But beyond that, the community itself heals, giving us something no treatment alone can provide, and sense of belonging and the feeling that we're not alone. And this is about shifting power, moving from being passive recipients of care to active partners.
Thank you, Kateryna.
Thank you.
Okay, so next we would like to invite Spiros Kronis, and he's going to speak about participation and empowerment. Thanks, Spiros. Я спікера не чую. Ви чуєте спікера? Spiros, we can't hear you. Оператори, ви чуєте спікера?
Yeah. I was saying Is everything all right now? So to speak louder?
So you got 2 thumbs up. I think you're good.
Okay, yeah, I'm continuing.
It's fine. It's fine, yeah.
Okay, so I'm doing, yeah, I wanted to say that participation is not just a good idea, and it's a fundamental right, especially in times of crisis when young people often feel like their lives are being saved by forces entirely outside of their own control. Mental health care should be the one place that we get power back, and quality standard 1.2 calls for shared decision making. A young person, especially navigating on the complexities of trauma and displacement, being invited as a partner in their own care is transformative. In this transition from being an object of clinical process to being an architect of their own future. As Ukraine continues to strengthen their mental health system, these standards are a roadmap to ensure that modern care means empowered care. It means ensuring that every young person has access to clear, youth-friendly information so they can make informed choices. It means recognizing that there are leading experts in their own lives. When we empower and youth participate, we aren't just improving clinical outcome, we're restoring dignity. We are telling a young person that their voices matter, that their choices have weight, and they have the right to lead their own healing process. When we share power with us, you don't lose authority, you gain a partner, and together that partnership has built true resilience. Thank you for your dedication in our shared future.
Thank you, Spiros, and the rest of the YAG for really important perspectives from you. And I will pass back to Jen, who I think will then pass on to Robert. Thank you.
Можете вивести Дженніфер Холл на екран.
Thank you so much, Hannah. Thank you so much to Hannah, Paul, Kateryna, and Spiros. It was very fantastic to hear from you. And this youth advice group, I have to say, they're really core to our work. They bring in so much, so we're very grateful to them. For the next, should I hand over to Robert? Is that right? Or is there someone else?
Yes, indeed. Hope this is the most exciting part. Do you see my slides now? Okay, move them. My name is Robert Vermeiren. I'm a child and adolescent psychiatrist and a professor of child psychiatry at Leiden University Medical Center. And also, as Jörg Fegert said before, co-chair of the policy division of the European Society of Child and Adolescent Psychiatry, the ESCAP. And it's an honor to be able to talk to you and present on the power of connection and about holistic diagnosis and experts by expertise. And what I will do is give a little bit background from my discipline of child psychiatry on the reason why I'm so thrilled of the quality standards by WHO and why I like very much to work together with WHO and Jen Hall and a lot of other people. I will not present alone. I will present together with Kateryna Beer, who reached her PhD recently on experts by expertise, and who's also joining us. And I'm very happy with it. Is Kaylee van Tilburg, is experts by expertise at our department. I mentioned her a couple of times through my lecture. What I will do, I will focus on the lack of youth-focused care at this moment, the value of holistic diagnosis. I will talk about recovery, which I think is key in our field and how we can want to change things. And of course, I will talk about expert by expertise that it gives added value. I'm going to do it. Kateryna Beer, who is an expert on this field, will do it. My story starts here. The picture in the background is the picture of Curium, is the child psychiatric clinic in Leiden. And what happens there is what you already saw also the sheets of Jen is an increase of mental health problems. We've seen it over the last 10 years about. And then you see this graph below is a graph from the UK, but it could have been from the Netherlands, where I'm from, an increase in anxiety disorders, depression, absolutely also in eating disorders, but also a lot of other problems, automutilation, suicidal behavior that we're struggling with. And the picture you see is the picture of Fleur. Unfortunately, we also had over time a lot of children who ended their own life, like Fleur. And this is picture because their parents are now starting a campaign in stimulating research in our field because they see there's a lack of knowledge on this field. But in 2015, we had also, not Fleur, but another one, some suicide in Curing for the first time in many years. And what we saw, it was a beautiful person and a very intelligent young woman. And we tried everything to help her, but we couldn't. We lost her. And that's why we thought we have to change our work. We have to invent new ways of working with these kids. At the same time, I met a lot of these kids from different organizations. For instance, from the NER, is a National Youth Council in the Netherlands. They have a subsection which is called Head Matters, and is all youngsters with experience in mental health because they themselves had mental health help. Kelly van Tilburg has been in this organization after she's been patient also in Curium. And also I met some people from ESCAP, is an organization in the Netherlands with youths who are experts by expertise and help other youths about the age of a bit younger with their problems. And also I met youth from our own youth council. And what he said is some quotes like this, like stop labeling, listen to me, see what I need. I also said then it's an eating disorder, then depression, next borderline. So what he said, it changes all the time. And also, do you treat me or do you treat my label? And one told very strikingly, it feels like there has been made a paper version of myself. And what he also said is, these expressions are about the way we do diagnosis, and particularly also about what you see in the left corner, DSM-5 classification system. After I met these youngsters, we went to them also, what you see some pictures around, we took them to the National Congress of Child Psychiatry in the Netherlands to tell their stories. And what they told is, we have to change how we talk with them, how we treat them. And then later I started a research project by Lisanne Gelissen, together with Branko van Hulst, who did some qualitative study in youths, because I wanted to go deeper and to see, is it true what these youths told me? And Lisanne has seen a large number of youths, and they said also that what you do in your practice is standard practices. It's not personalized. It's not based on the story and the needs that we express. And it leads more to alienation instead of helping, because they don't feel listened to. And they feel talked about instead of talking with. And so when they collaborate, it's because they must and not because they like to. And that's what I like about these quality standards, which has been also been discussed by Jen, because quality standards also tell us that we have to look at our way to children. And one of the problems that is targeted in these quality standards, it what I've underlined, is that services are not child or youth friendly, and there's a lack of training. So that's why we need to change the way we diagnose our children. Nowadays, we seem to look at the diagnosis in terms of classification. We see what you see in the left upper corner, and sometimes people tend to think that classifications in DSM are like somatic diagnosis, like a brain tumor, or epilepsy, or whatever, or an infection, which is not true. Because what you see in the right bottom is a wonderful graph from the Foresight Institute. You can find it also in Google if you find. I'm not going details, but it shows, you see in the bottom line, the bottom black line and arrow is the age, from very young prenatal to old age. And then in the y-axis, you see different fields of problems. Different fields of problems that can play. And you see that's a combination of biology problems, but also environmental problems and also developmental problems. So there are a whole bunch of problems that are playing when a child develops a mental health disorder. The books in the right upper corner are kind of, if you want to read about the development of psychiatry in our world and the development also of DSM, why it came, and you can read it in the wonderful book of Robert Whitaker, Anatomy of an Epidemic. But what we did with DSM, we made a kind of DSM-centric focus, which over-focused on individualization. We only look at the child. And what it also did dus in DSM is that we decontextualize. We don't look at the context, not only the family around the child, but also the broader environment, grandparents, neighbors, whoever. And that's something that doesn't help. But first of all, we tend to go also into instrumentalization. And that leads to what I've mentioned before, what you would say, it leads to alienation. It leads to what you see in the pictures below, at the green picture, is somebody who's alienated, who's alone, he's feeling solitary, and it doesn't help to connect to other people, so it disconnects. That book that I mentioned is a book written by somebody in my department, labeling with ADG and S. Unfortunately, it's only in Dutch, but it also states also to the advantages of labeling with DSM, because there are definitely advantages in communication and being able to pinpoint what something is, but also the disadvantages which I described here. Because of this, I started with Chanel and Rianne also another study, a study in youth with severe and enduring mental health problems, and the most complex youngsters, a study on what is behind it. Because we heard, okay, classifications are not the problem, are not the solution. How do we have to help them? And they wrote a review on this topic and did also a qualitative study and a field survey. And then you see some screenshots of a couple of the articles of Chanel Bansema, but a couple more that you can also read if you want. And our focus was on these children who are showing a lot of risk behavior, suicidality, automutilation, eating disorder, substances, and or of course a combination. And we were going into the background. What is underlying these problems and how do we help them? And what we saw is that the end point of having complex problem was the end of a year-long, and we mean really a year-long vicious cycle is happening. And Kaylee could tell this too, because Kaylee, before she came to us, had about 4 years of problems, which she had a little bit help from psychologists, but a lot of problems that she kept to herself, because she didn't want to be different from peers, or because she was also reluctant to tell about it. So it was a vicious circle of years, and that also developed after. In this vicious circle, we see that there are a lot of factors that play a role. First, not only classification, but mainly transdiagnostic factors. And these problems start in the early puberty, and then you have transdiagnostic factors like perfectionism, of insecurity, that are underlying all these classifications that we see in these youngsters. What you also see is that the problems are very heterogeneous. There are many different factors that play a role. So not only in the child as seen, but also in the context or the environment. But the contextual factors are also very important in this vicious circle. And also what we see, it's very dynamic through time. The problems change. At what moment is eating disorder, but then eating disorder fades and it comes depression or anxiety, or there comes automutilation. And so different things change over time. As regards the factors, I only name a couple, and you can see many more in the articles that has been written by Chanel Bansema. But of course, what plays a role is individual vulnerability. Often these kids already have problems before puberty in early ages, often starting already after being born. What plays an important role also is trauma. And I don't mean trauma in the only sexual or physical trauma, but trauma in the broad sense. Trauma also to maltreatment or being bullied through time at school. And I can imagine this is of course a huge problem in Ukraine now with the war going on, and a lot of trauma and a lot of people being alone and so forth. So it must be terrible to have to target these problems. What you also see, and what I already told about the long time that Kaylee needed to talk about our problems, is a lot of masking that we saw. We see that these youngsters, or often for years, don't talk about their problems. They mask them, and they feel alienated also towards their own peers, towards their parents and environment, and of course also towards their professionals. And then, of course, this leads to interpersonal distrusts, distrusting other people, and of course also relational conflicts with peers, with parents, and with professionals. And then you see that this vicious circle is happening over time for years and years, and ends in risk behavior, suicidality, automutilation, and a lot of other problems in these kids. Another study I want to highlight is this study by Ronald Bahamondes, who has now written a review on the social determinants of suicidality, kids aged 12 to 25. And his paper is about to be accepted in a paper, so it's now in press, you can say. And he collected 303 articles in which he investigated the social determinants of health, mental health, and particularly now in suicidal ideation. And it's based on a paper by Lund, who did it first in mental health in a broad sense, also adults, and he did it in suicidality. And you see here in the graph the different fields of problems that he investigated: demographic, economic, neighborhood, environmental, and social cultural. And we see that, of course, there's a couple of demographic variables that play around, and we see differences in sexes and gender. Economic problems, of course, poverty plays a role, and employment sign. Neighborhood factors play a role. Environmental factors play a role, and this is disaster exposure, plus, of course, armed conflict, as unfortunately happening in Ukraine. But what you see, what is the factor with the most factors are related to suicidality is sociocultural, and has to do with social rejection, relationship, number of friends, romantic problems, connection and relatedness, social support. So these factors in connectedness and support and social factors are very important in the origins of suicidality. And it's in suicidal ideation, which is the biggest graph now, but it's the same in suicidal attempts and in suicides which have been committed. So this is making a point about the value of holistic diagnosis. So we have to look broader than only to the child or to the classification. We have to look at the whole environment of a person. This relates to recovery, which I want to talk about before we shift then to expert by expertise. Because this means also that when we look at outcomes of the children, we have to look further than what we do now traditionally is clinical changes. We also want to change symptoms, reduce symptoms. But that's not the whole story, because symptoms often do not reduce. Symptoms, autism, ADHD, you can change a little bit, but not very much. But even symptoms of suicidality, you of course want to reduce, but they can often stay for whole life. And they don't have to be burdensome even then. We have to look further when you go to outcomes. And that is the concept of recovery. It means that instead of only looking to symptoms, you also have to look at the societal changes in a person, how people does it at home, with friends, hobbies, and at school. Our functional factors are also crucial. It means how are you functioning socially or neurocognitively. That's important. And this all needs to, the central one is the personal recovery. And the personal recovery has to do with how you feel, how you adapt in your life to the challenges that you have. And it has several components, which is shown now at the left side, KIME. It has to do with connectedness. How do you feel connected to other people? Of course, your immediately environment, the family, but the broader environment, also peers and other people in the society. It has to do with hope, and that's a very important one. We need to give hope. And that's also one thing that's lacking often in the classification-based diagnosis. It's very risk and disorder directed and not hope directed. And we need to give hope. But also important in the personal recovery is identity formation, which of course crucial with our young people we work with, because they're just struggling with identity, looking for identity. And of course, people want to have meaning in life. What is the sense of being here? And of course, empowerment and agency. And I can say this recovery-based view fits neatly into the quality standards that are that the quality standards want to find and to integrate in our work. And last of all, I want to talk about expert by expertise and the added value of it. It has to do with our view of the sources of knowledge that we use in our field. Traditionally, we use scientific knowledge, articles, or evidence-based knowledge. And we also use professional knowledge, everything that we have learned in our education or in our training. But a third field of knowledge is crucial, is experience. And it's experienced by the youth themselves, but also experienced by experts, by expertise. It also is experienced professionals, because we professionals, we have experience. A lot of us have experience with mental health problems. That could be a talk on itself. We're not going to talk about that. We're going to talk about the experts by expertise and what the advantages of their involvement in our work. And now I want to introduce Caroline de Beer, who's going to talk about her PhD trajectory, and who's written a couple of articles. I only now mention her systematic review, but she has also done some qualitative research in a group of expert expertise or people with mental health problems on the value of expert by expertise. Caroline, I pass the word to you.
Thank you very much, Robert. Yes, my name is Caroline, and I conducted a PhD on the involvement of youth peer support workers, or I call them youth peer support workers, but sometimes they're also called experts by expertise. And I would like to start with introducing you to what a youth peer support worker actually is. To become a youth peer support worker, someone has often had experience with adversities or with mental health treatment or mental illness. And when someone starts to reflect on these experiences, someone starts to talk to other people about mental health experiences. Someone's able to use these personal experiences, but also use the experiences of others to talk about mental health. And someone can be said to have developed experiential knowledge. And when a person has developed skills to safely and valuably share experience and knowledge to support other people and to support policy, that's when we can call someone a youth peer support worker or an expert by expertise. And experts by expertise can utilize this experiential knowledge in a variety of roles. For instance, through providing emotional support to young people that are currently in treatment, but also to improve policy, research, and practice. And in doing so, in using youth peer support workers and having them represent these experiences, they can help services to become more youth-friendly, more culturally appropriate, and more aligned with young people's needs. Can I go to the next slide, please? And the added value of having youth peer support workers or experts by experience in practice and in policy and in research is that young people often experience more freedom, more autonomy, and more power when they talk to youth peer support workers compared to other healthcare professionals, because they feel that they can talk about things that are important to them and that they're not aligned with that they do not need to talk about treatment goals, for instance. And because of this, young people often feel more heard, more accepted, and more understood in relationships with youth peer support workers. They also experience the relationships with youth peer support workers to be real and to be authentic, because they're grounded on sharing living experiences. And having a young person talk about their experiences with mental health problems with youth peer support workers allows them to better cope with the mental health problems of other people currently in clinics. It allows them it gives them more hope and more perspective for future. Can I go to the next slide, please? But in order for a youth peer support worker or an expert by expertise to work in practice, there are certain requirements. They need to have reached stability in recovery. Full recovery is not needed, but someone needs to be able to sufficiently help others. It's also important that when a youth peer support worker works in treatment for young people, or works to improve practice, to improve care, that their experiences align with the experience, with the organization and with the youth that they help, because this allows them to provide more insight in youth culture and to improve practice. And a youth peer support worker should know which experience to share without burdening oneself or burdening someone else. For organizations wishing to work with youth peer support workers, it's also important that the culture that the youth peer support worker is going to work in is appropriate. It should support a recovery-oriented approach. It should support autonomy, and it should allow for youth engagement and youth participation. Organizations should also be flexible when they want to work with youth peer support workers. Young people often want informal context, informal relationships with experts by expertise or with youth peer support workers, not planned relationships like they often have with other healthcare professionals. And there should be clear arrangements in place for organizations wishing to work with youth peer support workers. There should be a clear division of tasks, honest rewards, honest financial compensation for experts by expertise. And people should have a clear view of the goals that the organization has with regards to implementing youth peer support workers, so that everybody is on the same page. Thank you very much, and I think we can move back to Robert.
Caroline, and then I'll finish this talk about connection and about the value of involving expert by expertise of youth peer support workers with this and with this overview of the quality standards which have already been highlighted by the youth of WHO. It's crucial to have youths being involved in policy, but also, of course, in our direct clinical work. And therefore, I'm very happy that Kaylee is with us. And now Kaylee, who is expert by expertise at Curium, will talk a little bit about her work and the strength and the value of experts by expertise. Kaylee, the word is yours.
Yes, thank you, Robert. My name is Kaylee van Tilburg. I work as a youth peer support worker at the Child and Adolescent Psychiatry Division of Leiden University Medical Center in the Netherlands. As Robert already said, I struggled a lot with mental health difficulties, mainly in my teenage years, but also now still with disabilities like autism and PTSD. But throughout all the challenges that I faced in my life, I also got the opportunity to help others with these experiences, and that means a lot to me. It also means a lot to my recovery and my identity as a person, but it also means a lot to the youth that I help. And I was asked to tell you a bit about what I do as a youth peer support worker. I have now worked as a youth peer support worker at Leiden for about 4 years. And at Leiden, I have a few roles that I do. I contribute to research by providing input from my lived experience perspective. I sometimes assist in teaching, and that's also how me and Robert got to work together and get to know each other better. Because I started out assisting Robert in his lectures he gives to the medical students here in Leiden. And that really sparked a passion for me about sharing about my own difficulties and using those experiences to help others. But a big part of what I do is also supporting the young people that receive treatment at Leiden. I do this by visiting the units we have, including the high intensive care units for acute psychiatry. And a few things I do is I facilitate weekly themed discussions about themes that are relevant for recovery, with the goals of getting to talk about these topics, but also to let the youth that are participating know that they're not alone. It is very important for them to be able to talk with each other about it, but it's also very important for them to have me also participate, and sometimes a colleague of me as well, to also learn that some struggles are very normal, and to give them a certain perspective. And that's also the thing I really focus on while talking with these youths, is to really radiate that I do believe they can recover. And I hope to be also a living proof that it is possible to recover. Because when I was doing really bad in my teenage years, several people told me I would never recover, which is an insane thing to say to a teenager. But it's more important for me to be able to use these experiences in my work now. I also work individually with youth. This can look like a talk once a week, going for a walk, thinking about what they need in treatment, and supporting my colleagues in the treatment they are giving. And I think a very important thing about youth support work is the perspective that you can give youth that are really struggling, but also the feeling youth get when they talk with youth support workers. They feel understood, they feel heard. And this also gives me some advantage sometimes, because they feel heard and understood, I can also explore topics that are really hard for them to explore, which is a very valuable tool we can use in a treatment. However, besides many advantages, there's also some disadvantages to my current position. In the Netherlands, we are, I think, pretty excited about using more of our lived experiences, but you may encounter colleagues that are really hesitant to work with you, and this usually is due to prejudice, thinking that peer support workers are vulnerable, feeling very confused about what a peer support worker can do. And there's also in the Netherlands a limited opportunity for career progression. So there's also a lot of debate about what kind of education is needed to be a good peer support worker, but also a lack of clarity on how you can develop yourself as a peer support worker when you are working in an institution. So you have to be able to advocate for yourself a lot. And I do feel like even though that can be hard and a challenge for some people, it is really, really rewarding to be able to do this work and to also do this in together with other disciplines and really establish a good position for lived experience as well. Thank you. I'm not sure who will talk next, if Robert's the one that's gonna...
В нас є питання. Спікери, чи ви готові відповідати на питання?
Yes.
Угу. Перше питання буде від мене. На слайдах в Роберта була така person-focused care. Чи можете ви трішечки розширити, що це, про що це?
That's a good question. Person-focused care, it's something that we are further doing research on now, because even tomorrow there's a huge conference also, a huge conference, work conference with different disciplines also to elaborate on how can you do it. It's kind of diagnosis where you assure that the youngster and the family feel heard, and that you have their story and their perspective, and that we not only focus on the problems that arise, but also on all the good parts of a child and the capacities and the competencies. And also that we not only focus on the child itself or the youngster itself, but also on the environment. Because we consider mental problems not as an individual problem of the youngster themselves, but as an interaction between the child, youngster, and the environment. So it's more in an interaction. And also then, as regards what plays a role, is to see what how the individual challenges in this child, and it can be on, of course, still individual things, but it can be in the environment, in the parents who struggle, or it can be in a broader environment. It can be poverty. It can be, and so it can be many different. And that's what I see as personal help. And I see that Kaylee is nodding, but maybe she can add, because Kaylee also is involved in one of our studies in which we are working on this issue. But maybe, I don't know if you have something to add, Kaylee?
Yeah, I think that what you said is very important. Like, especially at Leiden University Medical Center, we see a lot of, well, we call them complex, is a bit of a term I'm not always very happy to use, because they're just children struggling. They're not that complex. But when you struggle this much that your life comes to a full stop, it's usually not easy to recover that, and especially not in your teen years when you're also developing and figuring out who you want to be. So we really have to look beyond the whole idea of, okay, you have some symptoms and we will help and improve them, and look at the whole system of a child, which also prevents them relapsing, because we have a good stable basis to build on.
Yeah, and maybe to add, because I don't know how the diagnostic work is done in Ukraine, but I'm talking from a Dutch perspective, where we see that very efficient instrumental diagnosis based on classifications has gone way too far over many years. And I don't say we don't have to throw DSM, ICD out of the window. We need to some of these classification like autism and the spectrum still to be used, but we have to give them a little a smaller place, and that's maybe a cultural thing, is that instrumental way of making diagnosis, also forced by the mental health funding agencies, was going too far. So I don't know how it's in Ukraine. It would be very interesting to know about that. But of course, that's an other topic.
Наступне питання англійською. Я його і зачитаю англійською, тому тут буде трішки перекладачам складно туди-сюди все це робити. Олена Галушка питає: What are the essential components of recovery that you consider non-negotiable, and how long should the recovery process ideally last?
Kaylee. I can answer, of course, but you have it.
I feel like that really depends on the situation. In my case, being diagnosed with autism at 15, being diagnosed with PTSD even later, ADHD later, I have difficulties that led me to just like I couldn't handle it anymore when I was a teen because I was setting such high expectations for myself and blaming myself for all the things I couldn't do. These things I now have learned to live with. But for me, recovery might never really be over. I can get to a point at which I can say, okay, I can comfortably live with these difficulties because I know how to accommodate myself. But that's really a debate going on as well under the lived experience workers is, are you ever really recovered, and at what point can you say that? Might be easier if you just come to a psychologist with a depression and you're like, I don't want to be depressed anymore. You help the depression and it might be somewhat fixed, but still then you will always live with some vulnerability. So maybe Robert can elaborate a bit on the clinical perspective of recovery, but sometimes you may never really stop recovering, I guess. Yeah.
Yeah, indeed. It's a very broad concept, recovery. So I think there's not a clear answer to this. I think it's very individual what is most important. For the one person, it will be clinical recovery. I want to get rid of my symptoms when you have a bipolar disorder. For another one, it will be more like I want to be able to have a societal function, of to function better. When you have another diagnosis, so it will be very individual. I think that's a nice thing about our field also, that it's very personal and we have to keep that. It can take for years, but that doesn't mean that somebody who isn't fully recovered needs more help and more professional or psychiatric or psychological help. I think a lot of recovery by persons can be done on themselves or by preference with a direct environment, with context, with connection with others. That's what we, and that's why in the Netherlands I want to make a link to the youth peer support work, so experts by expertise. You have a lot of expert by expertise houses at this moment, where people who are not fully recovered, which we find help with themselves, and that is very strong because they find together, they find a meaning in life, they find this personal recovery, and that's what we want to achieve, of course.
I think that what you say, Robert, is spot on. We have a very clinical perspective of recovery, but recovery is more of a personal thing to go through, and sometimes you hear about youth that are maybe like still struggling with suicidal ideation, that kind of stuff, of which a psychiatrist would say, okay, that's not recovery because you still have too many symptoms that we think are very debilitating. But then when you ask the youth struggling, they're like, oh no, that's not the thing that I'm worried about. So I think we really have to like keep in mind that there's two perspectives to this recovery as well. Yeah.
Наступне питання звучить так. Чи передбачає ваш підхід у роботі з підлітками роботу з їхніми батьками? Оскільки у першу чергу, виходячи з досвіду роботи з випадками ризикованої поведінки, самоушкоджень, зазвичай виявляється, що там велика прогалина у розумінні батьків щодо потреб власної дитини.
People understand completely that it's about the role of the parents, because it's difficult.
Давайте ще раз. Чи передбачає ваш підхід у роботі з підлітками роботу з батьками? Оскільки у першу чергу, виходячи з досвіду роботи з випадками ризикованої поведінки та самоушкоджень, зазвичай виявляється, що там велика прогалина у розумінні батьків щодо потреб власної дитини.
Yes, very good question. That's very often. Yes, we do. I've seen, I'm now 20 years working at Curium, and I see a lot of shifts from working with the individual children towards more with the context and with the parents. And beginning when I came, I was trained more systemic. I always saw families. When I came to Curium, I saw parents who came with the children to Curium and came to deliver it to the psychiatrist and kind of fix it, and that doesn't work. So what we changed is that we now have made a new kind of intake or diagnosis system where we say we work with families with children with problems. So we work with families, and we always invite the whole family. And not in the sense that you are the fault or you have caused it, not at all, but you explain, because they know when you have a child with a problem, there's always interaction between you, and there are a lot of things that are happening, and that we need you to understand your child, and we need you for the future. So that's what we always do. And particularly when there are problems like automutilation or suicide, we want to involve the parents, because as you say correctly, we often see a gap, because parents, they are, when your child, you love your child, and when you see that your child is suffering and wants to end your life, it's terrible. And then you see a lot of emotions, anxiety, depression, also anger, and so forth. And that's what you have to break. And what we've done now, and that's another study we're doing, is on group therapies for parents. Group therapies for parents of children who are suicidal. So we now particularly invite the parents, and it's a group therapy based off nonviolent resistance and dialectical behavior therapy, but mainly nonviolent resistance, in order to help parents understand what is happening, and in order to diminish the gap, because we know the gap that is created between the parents and the child is making the problems worse, and they become more lonely, so more suicidal. That's what we want to heal that gap. And these group therapies are working very well. But this is new development, and it's now an ongoing study at this moment. We are seeing how can we improve this group therapies. But my message is really, yes, involving parents is indeed difficult. It's not easy, particularly these problems, but it's also really crucial in sense of that connection. And what we now also doing on the sense of parents is that we hope we can involve parents as experts by expertise. Like the mother of Kaylee is also taking part in our studies, and would love also to be involved in helping other parents in coping with their emotions.
And can I also add to this, because I also work as a psychologist for Curium, and we also do a lot of treatment at home. So where we go to families at home and to see the interaction between the children and their parents, to see how we can provide interventions at home. So I think that's also something we do at Curium,
which is of course a little bit more easy in the Netherlands, because it's a smaller country than I think Ukraine. But
таке ще питання від пані Ірини Лебеденка. З вашого досвіду, на які перші сигнали у поведінці дитини батькам варто звертати увагу, щоб не пропустити емоційні труднощі в дитини?
It's a difficult question, because there are no specific symptoms, and I must say that I'm also struggling with this. I told you that Kaylee struggled years with problems herself without talking to other people, and that's that masking alienation I was referring to. And I really don't know how to, because I talk about youths also age 12 to 16, and they all get into puberty at what time, and that gives problems, and there are no really specific problems to target. But of course, what you have to look at definitely is changes in functioning. When a child starts dysfunctioning, when it's not doing at school, with friends, in hobbies, or at the family level how it did before, then I think it's needed to talk with the child. And what I also say is to keep ears open towards other small things that the child does or says something, and they says, I don't want to be here anymore. So then it's important to start talking with it and to understand where is this coming from. It can be temporary sadness, but it can be a sign of a more deeper underlying problem.
В мене є питання. Як в Нідерландах побудована робота з батьками, якщо, наприклад, спроба самогубства вдалася і дитина загинула? Яку підтримку можуть отримувати батьки?
Oh, that's yeah. There are in the Netherlands, of course, there's one organization, 113, who's a helpline for suicidal persons. You can chat with them and call with them, but they also can support when there's indeed a suicide which has ended in the child dying, so they can help. And there's some psychologists and nuns who are trained in working with these parents. And also what I know is that there's contact between the different parents. So the parents of Fleur, the photo I showed, I know they have contact also with other parents, kind of self-help groups, because it's terrible. I can't imagine one of my children doing. It's difficult to understand why this happens. So these are the ways that people are helped.
І ще одне питання від мене теж буде. В нас були такі кейси, бувають кейси, коли є публічне, скажімо так, самогубство, яке транслюється в інтернеті. Зазвичай воно групове. І ми обговорювали це декілька разів в експертних групах. І питання про комунікацію стосовно таких випадків. Бо випадок вже є в інтернеті, його поширюють, наприклад, там в Телеграмі або десь ще. Яка, на вашу думку, які є за і проти того, щоб це комунікувати в громаді, наприклад, в місті?
For this, maybe if you do more webinars, I would advise you to maybe invite people from 113 from the Netherlands who have they have a website where there's a lot of educational and teaching material also for people how to talk with children and so on. And they also have a lot of a list of things that do's and don'ts in this sense. And I know that social media is something we all struggle with. But I know that there's kind of media code that suicides is not something that you mention. And when there is an article on suicide in newspaper or so, then it's always important to mention 113 as a chat opportunity or a calling to opportunity to go to. And also advice, never mention the method that is used because that triggers people. But of course, that's the media we have control over. Instagram, YouTube, whatever, it's something we don't have control over. I think we have to improve our means to influence these social media companies. That's something that Jörg Fegert is also working on. He's in different committees also in Europe on social media, because the influence of social media we see also absolutely in the Netherlands.
And maybe I can just come in as well and say that I've put in the chat a resource that WHO has specifically on this topic on preventing suicide, a resource for media professionals. So it's here in the chat. And to say there's been a lot of research into this, and in this guide there are some do's and don'ts, of course very aligned with what Robert was saying, but just for you to be aware of as well. Thank you.
Так, є ще питання від пані Наталії Голод. Чи є у вас досвід залучення до терапії осіб з порушенням ментального здоров'я ерготерапевтів?
What is exactly? Yes. Okay. Who are experts by expertise or?
No, I think just including them in the treatment.
Okay. We have a variety of therapists that we include at the same time. And I regretted to say this because I think they're very valuable, even also like music therapy and all kinds of creative therapy. It's very good, but it's under discussion by the funding bodies in the Netherlands whether they should be funded in therapy.
I'm not an expert on this, but I do think there are a lot more adults working with therapists here in the Netherlands than youth.
І в мене є питання до учасників молодіжної панелі. Ми наразі в ЮНІСЕФі теж створюємо такий молодіжний каунсел, молодіжну панель. Уявімо собі, що наші українські учасники, молоді люди, будуть давати нам поради, як ЮНІСЕФу, як працювати з ментальним здоров'ям, що робити з сервісами по ментальному здоров'ю. Що ви порадите їм? От як бути ефективним в такій молодіжній раді, в молодіжній панелі? Що робить вас ефективними, з якими труднощами ви стикаєтесь, що ви робите, чого не робите, що вам подобається про ці панелі, що ні?
Great.
Does one of our youth advisory group members want to take this one?
For me, it's difficult to talk about like your sort of perspective for Hannah and Jen, like the organization. But what is, at least in my experience, important is to really be heard and be involved in processes. Have like your opinion not just be heard and it's like there, but actually seeing things getting implemented based on your suggestions. I've experienced some tokenistic youth approaches where they just wanted a young person to be there just to show it, but that actually our voice was not heard. And it's also important to make sure if you're working with people with lived experiences that they can always have a bad day, like a mental health issue coming up, to just make sure we are just humans as well. And yeah, that's my take.
Thank you, Paul. Does anyone else from the Youth Advisory Group want to answer any of them? That's okay if not.
I think that what Paul said resonates with all of us.
Thank you, Kateryna.
Зараз я перевіряю, які ще є питання. Є дуже багато слів подяки. І слів подяки, в тому числі і перекладачам, і слів подяки за те, що ми саме так організували цей вебінар. Питають, чи буде запис. Так, українською запис вже є на YouTube, англійською запис буде, може, завтра або післязавтра, як тільки ми його змонтуємо і викладемо на каналі доктора Булавінова. Підписуйтесь, будь ласка, на цей канал і також на Telegram, щоб отримувати повідомлення про наступні вебінари. Я дуже дякую всім спікерам. З нашої сторони це було трішки ризиковано. Ми ніколи такого не робили, що було стільки спікерів. Десь ми, здається, переплутали когось і підписали не так, але ми дуже старались все підписати, щоб воно було так, в нас точно. Тому вибачте, якщо ми когось підписали не так. І ми дуже дякуємо як учасникам молодіжної панелі, так і Кейлі за такий особистий досвід, яким ви поділились. Це дуже-дуже важливо. Ми будемо до вас приходити з ідеями, може пропонувати вам ще інші вебінари в цьому ж ракурсі, бо не всі питання ми розкрили. І ми вам дуже дякуємо за підтримку України і за те, що ви в свій неробочий час, вечірні часи витрачаєте енергію і час для того, щоб підтримати нас і поділитись своїм досвідом. І ми дуже-дуже вам за це вдячні. Тому сподіваємося, що скоро вас побачимо в інших вебінарах. Всім гарного вечора, всім, хто в Україні, сподіваюсь, тихої ночі, хоча попередня не була тихою зовсім. Подивимося, що буде в нас сьогодні. Дякуємо.
Thank you. It went wonderful.
Thank you, everyone.
Wish you all the best.
Thank you all.
Thank you.